very much, Dr. Vijay, for the kind introduction, and I would like to thank the organizing committee for inviting me to deliver this topic, which is a very personal view of myself, combined together with some evidence and clinical experiences that I have accumulated over the years. Before I start, may I have a show of hands? How many medical doctors? How many are non-medical professions? May I have a show of hands who are the doctors in the house? Okay, so I have about half of the whole. But for today's lecture in 20 minutes, I will not be focusing on how to treat patients. I will not be focusing on treatment algorithms and so on, but I would like to show to you a rough structure of how our healthcare system can move to cater for this particular demands, cancer survivor, and in specific to my field, colorectal cancer. So this is where I have been serving for the last 5 years. I've just moved to a new hospital to set up a new colorectal service. It is not an easy journey. So these are the things that I will be talking about. So I will start off with some definition, look at some statistics and data for impact of healthcare, look at the challenges and symptoms faced by colorectal cancer survivors, and I would like to show you what are my views and what are the evidence to develop a more holistic approach and what is the future direction. So very simple definition, colorectal cancer, I think everybody should agree that it is a malignancy from the lower GI tract, the colon, rectum, which is clearly defined, but I would also like to say that a lot of database include anal cancers as well in their database. So, and this is the major bulk of cancer work that we do in our profession. What about cancer survivors? Now, this is a very difficult thing to define because as I look through the literature, there are many different versions. So I would like to share with you the longest surviving definition, which is from the Coalition of Cancer Survivors from the United States. So it says that the survivor is being defined as the person who has been diagnosed with cancer from the time of diagnosis until the end. So it will include the treatment process, possible cancer-free recurrences. It includes this spectrum, okay? Some may argue differently. I will show you a bit later. Then later on, the definitions were expanded to include incurable cancers, in which I think it was well covered by the first speaker, and also caregivers, families. So these are what we term as cancer survivors. Now, what are the impact of colorectal cancer? Now, in epidemiology, it is quite clear. We know colorectal cancer is the second most common cancer in the country. Okay, number 1 for men, number 2 for women. Okay, so first point, it is the most common. Second point, colorectal cancer, in fact, comparing to many other malignancies, they are relatively easily preventable, treatable, especially in early stages, therefore leading to much better survival rates compared with other cancers. All right? So what are the impacts of these data? So we look at, I've compared the regional data of overall mean survival. We look at our region, Thailand, Singapore, United States, Europe, so roughly around 50 to 60% survival rates in 5 years, inclusive of all stages. And looking at Malaysia, Malaysia's statistics are a little bit scattered. So I've put it in red color because these are the numbers that we have taken from major tertiary centers, local data. But then, when we look at the National Cancer Registry, the overall 5-year survival rate is about 18% in general, and it is also stratified according to stages. But this is not the point that I want to highlight. The point I want to highlight is that you look at the circles. So what do we conclude? There is a significant, meaningful survival for all stages. And now we are pushing, colorectal cancer is pushing for stage 4 diseases treatments, the survivors will also increase, and it will become a statistic in our healthcare system. So how do we treat colorectal cancers? I'm not going to teach about this. This is a whole myriad of concepts, alternatives, treatment options from surgical field, from oncology field, from multidisciplinary approaches that we have available in the country to treat them. And so what are the impact is, so now looking at research purposes, now the research fraternity would probably narrow down the definition, meaning that survivors are those with stage 1 to stage 3, treated and no evidence of disease. Okay, but I don't think this is purely for research purposes in terms of collecting data, looking at symptoms, quality of life, and so on. Now, long-term follow-up, health maintenance, and lifestyle modifications. So it remains the most important components of care in these cancer survivors. So, and this emerging group of patients who are still having active disease, but living their lives like normal people, you will not be able to recognize them as having cancers if they are walking down the streets or even if you're sitting in the clinic waiting for your turn. Right? So these are the emerging groups of cancer survivors which will require health care. So this picture, I've had this picture because of one of my late patients who described to me from the time of diagnosis until the surgery, the chemotherapy, and all the treatments that came one shot. It was a shock. So he described it like an atomic bomb just blew off in his family. And what is left when finally all the treatments ended, there will be the period, the phase of survivorship. And how was it described? Looking back at all these historical photos and using my patient's own words. So this is how he describes: picking up the pieces, finding a way to live a new life, trying to fit in a new life, mending a broken life, trying to move on, trying to search for meaning. So I think even if we as physicians and surgeons who have successfully managed to treat a patient with relatively good outcomes, with good outcome measures, we fail to realize that they still need help in many aspects. So what are the helps that we need here? So I look at physical symptoms. Let's look at this from a doctor's perspective. These are a whole myriad of complications and outcomes that the patients suffer after a cancer treatment. Side effects of chemotherapy, side effects of radiotherapy, and most importantly, side effects from surgeries. And it is impossible to teach one single physician to treat all these diseases, or all these complications. And we look at non-specific physical and mental symptoms. What are the most common on the list? Fatigue, sleep difficulty, anxiety, depression, okay? Negative feelings about body appearances. When we talk about colorectal cancer, I think 70% of people will think about one thing: a stoma. Okay? Then this is why it is a bit unique in this sense. So, what about challenges, the things that are non-quantifiable? So, we managed to quantify them through research, and we find that the impact of quality of life is significant in all aspects: physical, functional, psychological, social functions. Okay, mental and physical quality of life is poorer. Okay, the most prevalent concern reported 1 year after diagnosis. These are all based on evidence. What are those? Fear of recurrence, fatigue, sleep difficulties. And are we addressing them? then when evaluated 6 months and 12 months after diagnosis, even up to 30% of survivors will have persistent symptoms and impairments, we call them. So what about social economy impacts? Limited physical activities, impact on the relationships, intimacies, okay, unemployment, financial burden, loss of income. Are we as doctors or healthcare providers in the position to help cater for this? Now, psychologically, constant fear and anxiety of disease recurrence, and I tell you this is real. I have just too many of patients every time coming for follow-ups, care, they will be so jumpy. A CEA level of 2 to 2.2, it will create so much of anxiety to that particular patient. You spend half an hour calming them down. You know, this is how much of an impact to them. Depression, and presence of a stoma, having negative feelings about their body figures. And so all these require good support. Okay, and I think this is also based on evidence, a strong correlation between physical limitations and depressions. The more physical limitations they have, the more depressed they are. Now, with 5 minutes left, let me move on to some of my key points. So what I would like to share is that there are a myriad of the treatments, medications, surgical interventions from multidisciplinary teams, from surgeons, urologists, gynecologists, oncologists, physicians, palliative care physicians, and all these people come together to treat the symptoms to improve the quality of life. Now, so even if we are able to do so with such a good healthcare system, and bearing in mind that Malaysia, the healthcare facilities are still not yet equally distributed. And taking into consideration, I'm from Sarawak, we still have a lot of deficiencies in fulfilling this multidisciplinary team. So how do we balance it? The clinicians have very clear-cut, measurable outcomes. I, as a surgeon, will measure my success based on cancer clearance, success rate. My oncologist colleague measured it based on survival rates. The palliative physician will measure it based on symptoms, QOL. But what about, so now then we come to a loop where when these figures are deficient, so we embark into research, training, subspecialization, service expansion to try to improve these numbers. Okay, what about this? Are we measuring this in our practice at this point of time? If there is, I'm sure there are, how many centers are able to do that? So then we move on to how to understand the unmet needs of these patients. So I break it down to three simple categories. First one is, how do we help the patients to interact with such a massive healthcare system? Multidiscipline, so many departments. When you go to a hospital, you get lost. Number two, how do we ensure that information is always available to patients, despite your busy schedules? So I have an example of patients 3 years down the line after surgery. Finally, one day he told me, "Doctor, I never knew that having my anus removed, having a pelvic surgery can cause so much of suffering, so much of pain." 3 years down the line. He was so polite to me the first 3 years. And when he's cancer-free, then he started telling me, "I've suffered so much because of this surgery." So he didn't know about it because the information that is available is scarce. It's difficult for them to obtain. And of course, number three, social support. How do we help them to gain access to social support? Then with this, we are able to deal. The patients can deal with the difficulties. they can change their lifestyles, and they can start accepting and moving on. So I've listed down a couple of important services that I think we need to incorporate into our healthcare system and make it available, readily available. So for colorectal cancer, it's a very important priority to have a good enterostoma therapy team. It is very important to have very good hospice care, ambulatory care for patients in a rural area. Cancer support groups, there are a couple of very active support groups, but are we able to reach out nationwide? Medical social welfare, social security organizations like PECESO, are they able to help to re-stratify them, get new jobs, income replacements, so all these issues, and most importantly, psychotherapy and physical therapy. So where can we improve? I will skip these few slides and go to my last concept. So my concept is, I think it is time that cancer treatment, especially in colorectal cancer, where I envision it, we have a colorectal cancer navigation system. So how do we put this system in place? We have a allied health staff, a senior nurse or a sister who is in charge of cancer navigation in an institution. And this institution, this cancer navigation becomes a one-stop center for multidisciplinary coordinations, for linkage to various support groups and coordinations, to give one-stop center to provide advice, medical care, and specialize in giving initial treatments. Okay, sudden onset of abdominal pain, stoma leaking. When you want to make an appointment with your doctor, it's next Tuesday. You're not going to wait until next Tuesday. If you move to emergency department, the staff may not be sure how to treat you. So the one-stop center would be this solution. And it will become a resource center and a counseling center. And this is how I envision how we can move forward. And last, how do we make it available to nationwide? Through Cancer Navigation Center, then we can link it up to all primary care facilities, government, non-government, universities, private centers, and this would hopefully enable us to reach out more effectively to meet the unbalanced needs of cancer survivors. So that's all from